Good morning, everybody. Good morning. Can we please settle at the back? All right. Good morning. I'm Dr. Kgabale. Today's topic is from the Division of Dermatology, and it's been sponsored by USERIN. And our registrar is Dr. S Daya. He's the one who's going to give us a talk on leprosy. Thank you.
Okay, great. Thanks so much, Dr. Kgabale. So, like Dr. Kgabale said, my name is S Daya. I'm a registrar in the Division of Dermatology, and I'll be doing today's talk entitled Leprosy, a Biblical Disease in Modern Times. So to start off today's case, we're going to be doing two clinical cases, just to show the spectrum of which leprosy can present. So clinical case 1 is Miss NN. She's a 28-year-old female patient from rural KZN, now living in Johannesburg. She is unemployed. She has no known comorbidities and presented with an 18-month history of progressive skin changes, first noted on the face, later involving the upper limbs and the lower limbs. Skin changes were associated with diminished sensation, primarily noted periorally and in the lower limbs. Of note, she reports that her mother also experienced similar skin changes, first noted in 2010. She did not seek medical attention for this and remains undiagnosed. So these are clinical photos of our patient. So in these, one can appreciate the leonine facies, which is a lion-like face, madarosis, which is loss of the eyebrows, and significant skin infiltration. Hyperpigmented indurated plaques were also noted in the eyebrow region, forehead, and cheeks bilaterally. In these images, one can note the significant ear and earlobe thickening and infiltration. Earlobe elongation may also be appreciated. The image on the right shows bilateral skin thickening of the areola. So here, hyperpigmented, indurated plaques were noted over the extensor surface of the arms, as well as the shins bilaterally. So other findings included thickened ulnar nerves palpable bilaterally, decrease in light touch sensation noted on bilateral lower limbs, decrease in pain sensation noted on bilateral lower limbs, left more than right. So in order to make a definitive diagnosis, skin punch biopsies were subsequently taken at 3 different sites, namely the left leg, the left earlobe, and the right arm. All 3 of these biopsies showed active mycobacterial infection, most compatible with the diagnosis of lepromatous leprosy. So in terms of histology, in this image, a mixture of foamy histiocytes and spindle histiocytes may be seen. These are classical histological findings of lepromatous leprosy. So this image shows acid-fast bacilli stained with Zeal-Nielsen stain. Note that the bacilli are found in clumps. So I've included our second case specifically to show the diverse presentation of leprosy. So our second patient is Mr. KT, a 38-year-old male patient originally from Mpumalanga, now residing in Soweto. He has no known comorbidities and was previously treated for pulmonary TB in 2023. He presented to the dermatology OPD with progressive enlarging skin lesions, first starting in 2017, initially involving the back and later involving the upper limbs bilaterally. He reports intermittent pruritus of the lesions, and of note, he has no known leprosy contacts and denies having any close contact suffering from skin changes. So in these images, one can appreciate numerous well-demarcated indurated erythematous plaques on a hypopigmented macular base. The patient reports diminished light touch and pain sensation within the lesions. So here we can see the same lesions involving the upper limbs bilaterally. The patient also reported diminished light touch and pain sensation within the lesions. The image on the left shows erythematous indurated plaques overlying his tattoo. So of note, important negative findings include no leonine facies, no madarosis, no earlobe elongation or earlobe infiltration, and no peripheral neuropathy noted. So skin punch biopsy was subsequently done in order to confirm the diagnosis. This showed non-necrotizing granulomas, Zeal-Nielsen stain for mycobacterium infection negative. There was still diagnostic doubt and difficulty in differentiating between cutaneous sarcoidosis and tuberculoid leprosy. So repeat skin punch biopsy was therefore done, showing non-necrotizing granulomas and neurotropism, highly suggestive of the diagnosis of tuberculoid leprosy. So in terms of histology, this image shows inflammatory cell infiltrates organized in well-formed non-necrotizing granulomas in the superficial and deep dermis, comprising of epithelioid histiocytes. This image shows neurotropism or granulomas tracking along a nerve. In the absence of staining of mycobacteria, this is highly suggestive of a diagnosis of tuberculoid leprosy. So, an introduction to leprosy. Leprosy is a chronic infectious disease with prominent involvement of the skin and nerves that is caused by the Bacillus Mycobacterium leprae. It is divided into two major forms that depend upon the degree and the type of immunity. Lepromatous with a predominantly Th2 response, and tuberculoid with a predominantly Th1 response. Leprosy is a serious health issue in a number of low-income countries. Although it seldom kills, leprosy represents a deforming, disabling, and stigmatizing disease. Once worldwide in distribution, leprosy is now seen primarily in tropical and subtropical regions of Asia, Africa, and Central and South America. Early diagnosis and prompt therapy are key components in the strategy to control this chronic infectious disease. So in terms of the history of leprosy, the earliest evidence of leprosy comes from a skeleton in India dating back over 4,000 years, uncovered in 2009. Leprosy has also been described in ancient Indian, Chinese, Greek, and Hebrew texts. It is believed that the armies of Alexander the Great contracted the illness when they invaded India and carried it to the Middle East and then the Eastern Mediterranean upon their return home. It is also traditionally believed that the armies of Pompey took the disease from Egypt to Italy during the Roman Civil War, and subsequent Roman legionaries spread the disease to the rest of Europe. Trade, invasion, and colonization subsequently spread the disease to the rest of the world. By 1200 CE, it is estimated that there were more than 19,000 leprosy hospitals in Europe. The incidence rapidly declined in Europe by the 1400s for unknown reasons. So the disease was thought to be highly contagious, and sufferers were forced to separate from society in hospices known as lazarets or leprosaria. Outside these hospices, they were feared and ostracized, condemned to wander the roads wearing signs and ringing bells warning healthy people of their approach. Leprosy came to be referred to as the living death, and victims were treated as if they had already died. Funeral services were conducted for those living with the disease, and relatives were allowed to claim their inheritance. Leprosy was considered to be a form of divine punishment and proof that the sufferer was embroiled in sin. So the leprosaria or lazaret is well portrayed in the 1959 movie Ben-Hur. In this scene, Esther can be seen bringing Miriam and Tirzah supplies in the Valley of the Lepers, while Judah conceals himself from them. The leprosarias were miserable places where leprosy sufferers spent their remaining days in isolation and facing severe discrimination. So this is a photo showing the island of Spinalonga off the coast of Crete, the last leper colony of Europe. Patients were sequestered from the rest of the community and forced to isolate on the island. When the cure for leprosy was discovered in 1948, the residents of Spinalonga were gradually treated and returned to good health and sent back to the mainland to rejoin the rest of society. The colony was permanently closed in 1957. It is now a UNESCO World Heritage Site. So perhaps the most famous sufferer of leprosy was King Baldwin IV, also known as the Leper King of Jerusalem. He suffered from extensive skin ulceration and ophthalmic complications, which led to his premature death at age 24. He was depicted in the 2005 film Kingdom of Heaven, wearing a silver mask in order to disguise his disfigurement caused by lepromatous leprosy. So interestingly enough, Robben Island was used as a leper colony between 1845 to 1931. Upon its closure, all buildings were burnt out of fear that the disease may spread. After the closure of the leper colony on Robben Island in 1931, leprosy patients were moved to the Westford Leprosy Hospital on the outskirts of Pretoria, which treated patients until its closure in 1997. It has now been taken over and is an informal settlement housing over 5,000 people. In 1873, a Norwegian by the name of Harald Bauer Hansen discovered that leprosy was not caused by divine intervention or human sin, but rather by a small rod-shaped bacteria known as Mycobacterium leprae. So this revolutionized understanding of the disease and allowed for the development of successful treatment by multi-drug therapy. So at the time of the discovery, Norway was seeing a rapid increase in leprosy cases. These illustrations dating back from Norway during the 1800s show the typical leproma seen in lepromatous leprosy. So in terms of epidemiology, in the early 1980s, 11 to 15 million people worldwide were estimated to have leprosy. Curative multi-drug therapy has substantially reduced the number of affected individuals. The number of new cases per year decreased from more than 500,000 in 2003 to about 210,000 in 2015, with only 175,000 patients requiring treatment remaining worldwide. So the goal of the WHO is a prevalence rate of less than 1 case per 10,000 people, which has been achieved in all but a few countries. Although men and women are equally affected, the lepromatous form of leprosy is seen twice as often in men as in women. Leprosy affects all races and ages. However, its peak incidence occurs in individuals between 10 and 15 and 30 to 60 years of age. So this image shows the worldwide prevalence of leprosy in 2016, the highest prevalence being seen in South Asia, South America, and Sub-Saharan Africa. South African cases were not reported in this year. So leprosy in South Africa has been a notifiable condition since 1921. The WHO target to achieve less than 1 case per 10,000 population has been achieved since 1997. An article published in 2002 suggests the greatest prevalence of leprosy in South Africa being concentrated in Mpumalanga and northern KZN, with the highest in Ermelo district. So both clinical cases previously described at the beginning of my talk originate from these regions. A study done at Chris Hani Baragwanath Hospital published in 2021 showed decreasing numbers of leprosy cases. However, new cases were still present and neurological consequences were not uncommon. Of the South African-born patients with leprosy in the study, most were from Gauteng and KZN. This may indicate clusters of active infection transmission in these areas. 45% of patients in the study had lepromatous leprosy. The specialist leprosy clinic at Barra was much busier before 2020. However, due to rife xenophobia and the COVID pandemic, most patients from India, Pakistan, and other African countries were lost to follow up, and we someday hope that they find their way back to us. So 3 requirements for the spread of leprosy are a contagious patient, a susceptible person, and close or intimate contacts for a prolonged period of time. In endemic countries, the vast majority of new cases are in children and young adults who have close relatives with the contagious forms of the disease. The risk of acquiring the disease from household contacts is 25%. The incubation period varies widely, from months to more than 30 years, but is usually between 4 to 10 years. M. leprae is spread predominantly via nasal and oral droplets, and much less often from eroded skin. Even after 1 to 7 days, the bacillus is still viable in dried secretions. Inoculation is via the nasal mucosa, or less commonly through breaks in the skin barrier. Transmission also depends on the infectivity of the contagious patient. Although leprosy primarily affects humans, it can be found or reproduced in 9-banded armadillos in the southwestern United States, red squirrels in England, and mice, and therefore may also represent a zoonotic disease in areas where these animals are found. So in terms of pathogenesis, the Bacillus M. leprae is a very small, slightly curved rod that is weakly acid-fast. It is an obligate intracellular microorganism that has a predilection for macrophages and Schwann cells or nerves. The major sites of involvement are the peripheral nerves, skin, mucous membranes, bones, and viscera, including the testes and the liver. The bacillus best grows at a temperature of approximately 35 degrees Celsius and therefore prefers cooler regions of the body, which include the extremities such as the nose, testes, and earlobes, as well as regions where the peripheral nerves are close to the skin. So the fact that the majority of exposed individuals do not develop disease implies that there is a variability in susceptibility and resistance, depending upon genetic and environmental factors. Susceptibility and the type of immune response appear to correlate with specific HLA types, such that individuals with HLA-DR2 and HLA-DR3 are more likely to develop the tuberculoid form, and those with HLA-DQ1, the lepromatous form. So as noted in the clinical cases previously presented, leprosy can present in a wide spectrum of clinical findings. The Ridley and Joplin classification divide leprosy into 5 forms. The 2 polar forms, namely lepromatous at the immunodepressed end and tuberculoid at the immunocompetent end. The 3 types of borderline leprosy lie between, namely borderline lepromatous, borderline in the middle, and borderline tuberculoid. Clinical assessment of patients requires an extensive cutaneous and neurological examination. So this image illustrates the spectrum of leprosy presentation, ranging from tuberculoid at one end of the spectrum to lepromatous at the other end. The borderline presentations lie between. Bacillus burden increases from the tuberculoid end to the lepromatous end, and cell immunity reduces. So lepromatous leprosy, the form with the least cellular immunity and greatest number of bacilli, is characterized initially by multiple, poorly defined erythematous, macules, papules, nodules, and clumps. Lesions are widespread and usually symmetric in distribution. The most common sites of involvement are the face, buttocks, and lower extremities. Infiltration of the skin of the forehead can lead to leonine facies. Additional signs and late sequelae include madarosis, saddle nose deformity, infiltration of both earlobes, and acquired ichthyosis or fish scaling on the lower extremities. Anesthesia in a stocking or glove distribution may develop, often together with enlarged peripheral nerves and neuropathic changes. Ocular manifestations such as lag ophthalmos, which means the inability to completely close the eyes, and corneal and conjunctival anesthesia, due to involvement of the branches of the facial and trigeminal nerves respectively, are sometimes present in severe cases. So image A shows the numerous erythematous papules and nodules on the forearms and hands that one might get in lepromatous leprosy. Image B shows infiltrated nodules coalescing on the forehead with leonine facies and madarosis. Note the ocular involvement in this patient. The extensive leproma, skin infiltration, and madarosis shown in this photo result in the development of leonine facies and resemblance to a lion. So borderline leprosy has features that are intermediate between the two ends of the spectrum. Cutaneous lesions are usually asymmetric. For example, there may be unilateral earlobe swelling. The severity of cutaneous and peripheral nerve symptoms abnormalities depend on whether the patient is leaning toward the lepromatous pole or the tuberculoid pole. Within the cutaneous blocks, hair is usually absent. So the images show erythematous blocks with central clearing, leading to annular and arcuate lesions. Note the ill-defined outer borders and well-demarcated inner borders of these lesions. In tuberculoid leprosy, only a few well-demarcated blocks are seen, and sometimes only neural involvement is present. The borders of the skin lesions are often slightly elevated. In some patients, the papules or plaques are erythematous, while in others, especially in darkly pigmented individuals, they are hypopigmented. The plaque should be examined for alopecia as well as anesthesia and hypoesthesia. Unilateral neuropathic changes, especially of the extremities, such as digital resorption, may be seen. So image A shows a plaque with slightly elevated erythematous borders and central hypopigmentation. Image B shows a large annular lesion on the cheek with a red-brown color and a rim of hypopigmentation. So this table just summarizes what we've spoken about regarding the lepromatous and tuberculoid poles of leprosy, with the borderline presentations lying in between. So the image on the left shows important sites of nerve examination that should be done when assessing a patient where leprosy is a consideration. The image on the right shows sequelae of untreated leprosy, including leonine facies, madarosis, earlobe involvement, saddle nose deformity, ophthalmic complications, peripheral nerve involvement, and sequelae thereof, such as distal digital bone resorption and neurotrophic ulcers. So the image on the left shows claw hand due to median nerve and ulnar nerve involvement. Note the digital resorption due to peripheral neuropathy. This digital resorption has likely given rise to the myth that leprosy causes body parts to fall off. The second image shows papal or benediction hand, which develops with ulnar nerve involvement. Sorry for the poor quality of this picture. This image shows the neurotrophic ulcers which develop as a result of the peripheral neuropathy. So saddle nose deformity may also be seen due to destruction of the nasal cartilage and bone. Gynecomastia may develop as a result of testicular atrophy, which occurs following invasion of the testes by M. leprae. So in terms of pathology and laboratory evaluation, definitive diagnosis can be made on skin punch biopsy, demonstrating characteristic histologic findings of leprosy, as previously discussed in clinical cases, as well as possible demonstration of the presence of weakly acid-fast bacilli in the correct clinical context. Slit smear examination is a test in which a sample of material is collected from a cut in the skin and then stained for M. leprae. So in terms of treatment, the WHO recommends multi-drug regimens that are safe, effective, and easily administered. When bacilloscopy is available and no bacilli are found, patients are considered to have paucibacillary leprosy and are treated with rifampicin monthly plus a sulfone, which is usually dapsone, daily for 6 months and then observed for 2 years. For patients with paucibacillary disease and a single lesion, single-dose therapy with rifampicin, ofloxacin, and minocycline has produced good results. If at least one bacilli is detected via bacilloscopy, the patient should receive rifampicin, clofazimine, and dapsone for 1 to 2 years, and then to be observed for 5 years. A second option is to combine a sulfone with clofazimine. Multi-drug therapy is extremely effective. Importantly, after the first dose, the patient is no longer infectious to others. All patients who complete the prescribed regimen are considered cured, as there are virtually no relapses. Of note, patients initiated on leprosy treatment may develop upgrading or downgrading reactions once multi-drug therapy has been initiated, but treatment should never be stopped in these patients. These reactions can be quite severe and can compromise nerve function. Patients suffering reactions need to be closely monitored and may be started on high doses of oral corticosteroids until the reaction settles. So these are pictures of our leprosy clinic held on a quarterly basis at Baragwanath Hospital. So we are supplied by the multi-drug treatment, also known as blister packs by the WHO and the Leprosy Mission of South Africa. And we keep these at our clinic, dispensing these to our patients ourselves. So in this photo, Dr. Fenter, a registrar within our department, is dispensing the multi-drug treatment to one of our leprosy patients. So take-home messages for today. Diagnosis of leprosy can be difficult due to the vast range of clinical presentations. Leprosy can still be an incapacitating and stigmatizing disease. Infection requires prolonged exposure to a close contact in order to be transmitted. It is now considered a curable disease with a good prognosis and excellent survival rate. It is very important to make the diagnosis as soon as possible and to examine contacts, since early treatment prevents disability. Recognition of leprosy in its initial phases by healthcare professionals is essential in order to reduce the impact of the disease. So acknowledgements for today's talk are patients, Ms. NN and Mr. KT, Dr. Musa, Dr. Bojwani, Dr. Selepe, Dr. Fasaki, and Dr. Fenter for helping me make up this presentation. And then our sponsor for today is Eucerin. So at the back, they've brought us sunscreens and Aquaphor for our Soweto Marathon, and then they've also brought us waters as well. So please help yourselves to that once we're done. They're brought to us by Celine, so she's the representative from Eucerin. They're quality products, they're very good. We use them for our patients, and they're also sponsoring our patients with sunscreen, our OCA patients and our patients that require sunscreen, with those that get like multiple skin cancers. So just like to thank them for that. Okay. And these are my recommendations.